Hello, I'm Asrar, interventional cardiologist, work at Bendigo Health. I'm going to talk about ischemic heart disease, a little bit about its basics and some treatment options. So let's start with this case of Mr. TB, who is a 38-year-old gentleman, presented to the emergency department, drove himself with complaints of chest pain for last 2 hours. While waiting to be triaged in the emergency department, he collapsed in the waiting area, and he obviously was resuscitated. His airway and breathing assessed were okay. He had no output. There was no palpable pulse, so a defibrillator was attached, and this is the rhythm we get. As we can see, it is obvious ventricular fibrillation. He's a 38-year-old gentleman, collapsed in emergency department with the ventricular fibrillation. What do? He was shocked by the defibrillator. It took 2 shocks to put him back in sinus rhythm. While waiting for the 12-lead ECG, we managed to get some more history out of him. He did not have any past medical history. He was a smoker. He had a strong family history of ischemic heart disease. His father had CABG by 3 at the age of 59, and he was not taking any regular medications. So 12-lead ECG was done, and it shows ST elevation in the inferior leads, which is lead 2, 3, and AVF. So what do next? We take him to cath lab. We shoot his coronary arteries. The left-sided system was okay. This is the right coronary artery. So this is the right coronary artery. It is supposed to be a big artery, but we can see it is occluded right in the middle. And there's a little bit of haziness, which represents blood clot. So he obviously had inferior STEMI due to occluded RCA. So we put the guide in, we put the wire inside the artery, we put the balloon in. As you can see, the balloon goes up, tries to open up the artery. We inject a little bit more contrast to see what's going on, and see there's a little bit of flow establishing in the artery, but not quite smooth yet. So we put some more balloons, do a little bit of more inflations, and then we put the stent in. This is the first stent going in. This is a metal scaffold. The stent is inflated, deployed. A second stent goes in, overlaps with the first one, and the second stent is deployed. So this is the artery picture I've taken after putting the stents in. You can see there's a clear difference. The occluded artery is now open, and there's a good blood flow in the artery. So this is how we have treated this young guy with inferior STEMI. We've opened his artery, we put 2 stents in, and his myocardial damage is minimized by doing this procedure quickly. Luckily, he was in the emergency department already when this happened, and there was not much time lag between the opening the artery and the event. So I'll show you this video to give you an idea of how the angioplasty works. So this is the metal stent that stays in the artery forever. and that means requiring antiplatelet agents for rest of the life. The usual recommendation is 2 antiplatelet agents for the first 1 year after the acute coronary syndrome, and then we can switch down to 1 antiplatelet depending on how complex the procedure was and various other factors. Sometimes we continue the antiplatelets for a longer period of time. And then although the current generation of stent is all metal, which stays in the body forever, there are a lot of companies now trying to develop new absorbable stents. The technology is not quite there yet, but in future we are very hopeful that this will be the way to go. And the idea would be that we put the stents in, it stays there for a year or two, does its job, and then disappears, so that the artery is not left with any residual metal. So watch this space. A little bit about ischemic heart disease now. This spectrum includes stable angina, unstable angina, non-ST elevation myocardial infarction, or ST elevation myocardial infarction. The risk factors for ischemic heart disease were established in this inter-heart study, and they described 9 potentially modifiable factors which account for more than 90% of the risk of infarction. And these include smoking, dyslipidemia, hypertension, diabetes, central obesity, psychosocial factors, diet, alcohol abuse, and lack of physical activity. There's one non-modifiable risk factor which is significant independent risk factor, and probably the most important, which is family history, genetics. So just to give you a little bit of insight, this is how the lifestyle has changed over the last few years, for a few decades rather. This is what McDonald's used to give us with this meal, the pack of chips, which was 210 calories, and now we have increased the size of our junk food, and now the current what they give is, guess what, 610 calories. And to burn these extra 400 calories, we have to walk for 2 hours and 20 minutes based on an average weight. So we obviously do not do that, but we do increase, we have increased junk food intake, and that has a significant impact on our life and risk factors. Dyslipidemia, which accounts for 49% of population at treatable risk of first MI, and the reduction in total and LDL cholesterol reduces coronary events plus mortality. It is important for both primary and secondary prevention. The rough estimate is that 10% reduction in the LDL level reduces the risk of future MI events by 11%. So it's a significant reduction. Most common treatment is statins, which do not only lower the cholesterol levels, but they also help to stabilize the plaque. They have antiplatelet activity as well as anti-inflammatory, so these are very useful drugs. There's been a lot of bad press about statins recently, but it's all non-scientific. But science tells us it's one of the best drugs that we can give to our acute coronary syndrome patients. Low HDL is also been associated with increased risk of coronary artery disease, and to date one of the only factors that help improve HDL is a lot of physical activity and walking. Hypertension accounts for 18%. Although the targets do vary a little bit depending on the risk factor profile and the age of the patient, but the general idea is to have it less than 130 over 80 millimeter of mercury. And there are various treatment options available, and there have been recent guidelines suggesting different agents for different associated comorbidities. But generally, if the patient has tachycardia or tachyarrhythmia, we give them beta blockers. If the patient have heart failure, cardioselective beta blockers and ACE inhibitors are highly recommended. For diabetic patients with proteinuria, especially ACE inhibitors or ARBs are good choice. People with angina, obviously beta blockers and dihydropyridine calcium channel blockers as well as nitrates are good choice. Diabetes accounts for 10%, which puts patients 2 to 3 times at high risk of MI and stroke. And an estimated increase of HbA1c by 1% is associated with relative risk for all-cause mortality by 1.26% increase. Mild to moderate chronic kidney disease is also associated with substantial increase in ischemic heart disease, and the treatment is usually ACE inhibitors, which helps the diabetic nephropathy. Smoking accounts for 36% of the attributable risk for first MI, and the incidence of MI increased 6 times in women and 3 times in men who smoke at 20 cigarettes a day. And the risk of recurrent infarction decreases by 50% at 1 year in patients who've stopped smoking. So the aim is to reduce the modifiable risk factors as much as possible and do not fall into this trap of Mr. Jar Harville, who was modified his risk factors but died anyway in 91. But that happens to everyone. A lot of risk scoring systems have been used to risk stratify the coronary artery disease, especially in the acute settings. And one of the most common and one of the most widely used scoring system is called STEMI score, especially in the emergency department settings. It is very useful, and it includes the age of 65 or more, presence of 3 or more risk factors for ischemic heart disease, prior known coronary stenosis of 50% or more, ST segment changes on ECG, at least 2 anginal episodes in prior 24 hours, elevated cardiac enzymes, or use of aspirin in prior 7 days. So 0 to 2 score means low risk of having cardiovascular event in next 14 days, and that essentially means that this patient can be treated as in the outpatient settings. Any score more than 2 should be treated more aggressively, and usually in the inpatient settings. Treatment of angina includes oxygen if the oxygen saturation is less than 93%. Nitrates are one of the mainstays of the treatment for angina, and that includes sublingual tablets or sprays, as well as for more long-term treatment options like Takotsubo mononitrate tablets. Beta blockers are the second choice for the angina, and usually short to medium acting beta blockers are preferred, like atenolol and metoprolol. Long acting beta blockers and cardioselective beta blockers are used if the patient also has LV dysfunction. Calcium channel blockers can be used as an alternate to beta blockers if the patient is not suitable for beta blockers. Other choices include nicorandil and perhexilin, usually as an alternate agent or as a last resort for medically managed patients. Perhexilin has a lot of side effects, so it's not a very commonly used drug. Other than that, the antiplatelet therapy is recommended, which is aspirin plus minus a second agent depending on the severity of the condition. And obviously cardiovascular risk factor reduction is very important, as well as the regular exercise program and physical activity. Now, aspirin is an interesting drug. It is the active component is acetyl salicylic acid, and the historical records show us its use, its extraction from the plant, especially the willow bark and leaves in antiquity. Hippocrates have described its use in powder form, extracted from willow tree in 5th century BC. So that's how old it is. It was not until 1897 when the chemists working for Bayer produced an synthetically altered version of salicylic acid, which was with less digestive upsets. Since then, pretty much since 1900 to present, it is the most widely used drug in the world. This is how it looked initially when it was formulated by Bayer. It was used to come in the powder form, and this is how their advertisement looks. They have listed few conditions which it was used for, including colds, pains, headaches, etc. And it clearly says on the marketing campaign that it does not affect the heart. It was in 70s when the mechanism of action of aspirin was discovered, And since then, a lot of trials, especially in 70s and 80s, have established its role in the heart conditions and its anti-clotting properties, which are very useful in the ischemic heart disease treatment. Further testing for angina includes stress ECG or stress echocardiography or myocardial perfusion scan. And then the more definitive treatment options are coronary angiography. Coronary angiography is still considered as the gold standard for treatment of coronary artery disease, plus revascularization if indicated, which is any angina that significantly interferes with patient's lifestyle despite optimal medical therapy, or people at high risk of ST elevation or non-ST elevation myocardial infarction. They should be treated more proactively, and the treatment options would include percutaneous coronary interventions using stents or an open bypass graft heart surgery. Non-STEMI is described as ischemic symptoms suggestive of an acute coronary syndrome with elevation in cardiac biomarkers plus minus ECG changes, which would usually be either ST segment depression or transient or new T-wave inversions. And the treatment for non-STEMI is initially medical, which includes nitrates, oxygen, and antiplatelet therapy, which is usually dual antiplatelet therapy with aspirin and clopidogrel. These days we use ticagrelor more often, antithrombotic therapy, and then we can give beta blockers for prevention of life-threatening ventricular arrhythmias in the acute settings. Recurrent ischemia is prevented by giving beta blockers, slowing the heart rate down, giving nitrates, and statins are used for plaque stabilization as well as for more long-term cholesterol lowering. ACE inhibitors and beta blockers are long-term therapies. Angiography and early revascularization is recommended for all non-STEMIs, and the optimal timing has been described between 4 to 48 hours of the event. This is an example of anterior ST elevation myocardial infarction. We can see clear ST elevation in the anterior chest leads, and there is reciprocal ST depressions in the inferior leads, which is lead 2, 3, and AVF. This is inferior STEMI, ST elevation in inferior leads. So apart from angiography, we can use a lot of useful techniques in cath lab these days to further assess the disease. One of them is intravascular ultrasound, in which we put the wire inside the artery like angioplasty. But this wire, through this wire, we put an ultrasound probe inside the artery to give us the inside assessment of the artery, and it can show us the plaque, lumen area of the artery, any dissection, anything else happening, and it can also give us the dimensions of the original artery and the plaque, and that can sometimes help us in deciding on the treatment options as well as the sizing of the stents to put in. OCT is another new modality which uses infrared light instead of sound, and it gives a much higher resolution of inside the artery pictures. And it can not only tell us the amount of plaque, but it can also give us the types of plaque, including fibrous or lipid-rich plaque, and it can also give us the vulnerability of the plaque, whether it is prone to rupture or not, or how likely the plaque is prone to rupture. It can give us pictures of thrombus inside the artery, and it can show us the stent inside the artery, and that a lot of times helps us to decide if the stent has been inserted optimally, or we need to further dilate it or put it next to the wall. Is it touching the wall or is it not touching the wall? You can see these small metal scaffolds, these arrow pointing, these are the metal bits of the stent, and these are like very, very highly accurate pictures. It can tell us about the plaque rupture if you're not sure about what is going on in the artery, whether it's a clot or something else. It can give us useful information. This picture is showing some thrombus in the artery, and there's a big cavity which is actually a plaque which has been ruptured in the artery, putting the thrombus in. Then there's a FFR, fractional flow reserve, which is an inside cath lab functional assessment of the lesion, whether it's significant or not. So what we do is we put the wire inside the artery and check the pressures before and after the narrowing, and then assess the drop in the pressure across the narrowing between, and look at the gradient. If it is significant drop in the pressure, then that would normally mean that the patient should be treated with stent or revascularization. This is an interesting case I often show to people at this stage. So this is a youngish girl in 30s who was an inpatient in ICU, and she was suddenly found. This is the upper side of this picture shows the baseline rhythm of her ECG, and then she was suddenly found to have this funny rhythm, which is at the bottom of the screen. And she was thought she was not responding to the calls, and then it looks pretty like the first, when you look at it first, it does clearly look at the ventricular fibrillation. So she was shocked out of this rhythm and went back to sinus rhythm. But now if you look closely at this picture, the heart rate is around 70 in the baseline ECG. Now, if you map this with the bottom ECG, you can see there are spikes, and which clearly correspond to the QRS complexes in the picture above. So the 1 spike, 2 spike, 3 spikes. So these are the normal QRS complexes, and everything in between these QRS complexes is noise. So whether she was scratching herself or moving or shaking, whatever, but it is not a ventricular fibrillation, and she was actually fast asleep when this happened, and she, for obvious reasons, she didn't respond, and she was shocked, which she didn't like very much. So we have to be a little bit careful interpreting the ECGs. We have to see the clinical context. This is not that an uncommon occurrence, especially in the elderly people. For example, people with Parkinsonism who often get with the shakes this sort of noise. So I'll show you this video just to wake you up a little bit. And this is essentially a communication between a junior emergency physician or emergency junior doctor with a cardiologist, and that is not very uncommon. So see how he...
Hi.
Hi.
Are you the cardiologist on call?
Yes. Who are you?
This is the emergency department.
Sure. What's the story?
There is a troponin. You need to fix it.
Okay. Tell me more.
There is a troponin. You need to fix it.
Can you tell me more?
The troponin is 0.3. You need to fix it.
Okay. Let's start from the basics. Where is the patient?
We moved her to the cath lab. You need to fix it.
Anything else you can tell me?
The troponin belongs to a 97-year-old lady from a nursing home. She is fasted. That is good.
Any comorbidities?
She is otherwise well. Except for...
Except for what?
Her temperature is 29 degrees.
Right.
And her pH is 6.8.
Really?
And she has a condition I have not seen before.
Which condition is that?
A systole.
A systole.
A systole.
Right. And you want me to catheterize her?
There is a troponin. You need to fix it.
Why didn't you tell me about it from the start?
I did. There is a troponin. You need to fix it.
No, not the goddamn troponin, the bit about a systole.
because then you might refuse to catheterize her.
Don't you think I'd have noticed a systole when the patient arrived in the cath lab?
It will not take you long to fix the troponin. You are very skilled with needles and contrast injection.
She is not fit enough for a haircut, let alone an catheterization.
There will be minimal door to balloon time,
I think she has other management priorities at the moment,
like the troponin.
like CPR.
Ah, they have finished doing that.
Oh. They have stopped doing CPR on someone in a systole.
Yes,
That means she is dead.
there will be minimal blood loss.
You know what? You're right. There is not much blood loss when there's no friggin' cardiac output.
You need to fix the troponin.
Please go away.
You are being obstructive by refusing to do my case.
And you are making my head hurt.
There is a troponin. You need to fix it.
I need to go and run into a brick wall.
If you have chest pain, I will consult cardiology for you.
So this was supposed to be a funny video, but you'll be surprised how often this actually happens. But what I'm trying to highlight is there are a lot of reasons for raised troponin levels or cardiac enzymes apart from coronary artery disease. I'll give you an example with this case. A 37-year-old Lebanese female presented to the emergency department with 4 hours of chest pain radiating to her left arm associated with shortness of breath. Acute onset, she is a smoker. She has a family history. Her mother had MI at the age of 75. She takes regular oral contraceptive pills and she has 3 children. Her husband had motor vehicle accident 2 days ago and she is affected by the recent war in the Middle East. So her heart rate was 88. Regular blood pressure was a little bit on the lower side. Saturations and respiratory rate was normal. She had dual heart sound, no murmurs, normal JVP, and she had mild bivasal Krebs, no peripheral edema. Rest of the examination was essentially unremarkable. This is the ECG, which shows some non-specific T-wave inversions, but obviously nothing drastic. However, her troponin was elevated at 2.7. So she was taken to cath lab. We had a look at the coronary arteries, which look pretty smooth and normal. This is the left system. We can see the left circumflex artery and the LAD. They all look okay. And this is her RCA, which again looks fine. There's no flow limiting obstruction or any disease. And then we do the LV gram. We put the catheter in the left ventricle and inject some dye to look at the function of the LV. So you can see the whole apex distal anterior wall and distal inferior wall is not moving. This is called apical ballooning syndrome. This is how the still picture would look like. And it's called Takotsubo cardiomyopathy. So she had normal coronary arteries with raised troponin, and this condition is called Takotsubo cardiomyopathy. And this name comes from the Japanese octopus catching pot, which looked very similar to this apex. And it's also called broken heart syndrome, and it's essentially a stress-induced cardiomyopathy. Which can happen related to stress. This could be any physical or mechanical stress. We've had patients after arguments with spouse. We've had patients after receiving high Telstra bills coming with this presentation. So it could be any stress. It was initially identified in Japan, and since then we have seen it's with a very high frequency. So it's not that an uncommon condition. It's 96% of the patients would be female, mostly elderly, but it does happen at a young age. So it involves significant LV wall motion abnormality. Usually the base of the heart is normal or hyperdynamic, and the whole apex is either hypokinetic, akinetic, or dyskinetic, depending on the severity of the condition. And coronary arteries would be normal as a rule. So So the other conditions which can give elevated cardiac enzymes with normal or near normal coronary arteries include dissection of the aorta. Aortic stenosis is an important cause. Prolonged hypotension can cause elevated troponin levels. Carbon monoxide poisoning, aortic insufficiency, or conditions, metabolic conditions like thyrotoxicosis and some other hormonal derangements. Cocaine abuse is one of the important factors. It causes vasospasm and coronary artery spasm and can give you transient ST changes in the ECG as well as troponin elevation. Myocarditis or myopericarditis can give you raised troponin levels. Myocardial contusion can give you elevated cardiac enzymes. So it's a mechanical trauma to the heart can also give you coronary artery disease like presentation. A lot of arthritis, including SLE and ankylosing spondylitis, can give you false troponin elevation. So I'll skip next few slides. This is another example of this similar Takotsubo cardiomyopathy, however with a variant that the apex is contracting but the base is not. So it's just a different presentation of this similar episode, similar syndrome. This is how it looks like. The base is contracting, but the base is not contracting, apex is. So it's just a opposite of the previous, but it is similar, same Takotsubo cardiomyopathy. The treatment of Takotsubo is, it was supposed to be a benign condition which self-resolved, but the recent research suggests that it is actually not that benign, and these patients are at high risk of developing future heart failure. So they are these days treated aggressively with the standard heart failure therapy. So this was all. Thank you very much for attending. If you have any questions, we can do them later, or the more than happy to answer any questions at any stage. You can send them to me. Thank you very much.